Hello everyone. Today we are going to explore ligament sprains and tears, one of the most common injuries encountered in musculoskeletal physiotherapy. Ligaments are critical stabilizing structures of joints, and injury to them can significantly affect joint stability, movement control, long-term function. Modern physiotherapy emphasizes not just healing the ligament but restoring neuromuscular control and functional stability. In this section, we will explore ligament structure and biomechanics, injury mechanisms, clinical reasoning, and evidence based rehabilitation. So, ligament structure and function. Ligaments are dense connective tissues connecting bone to bone. So, composition type 1 collagen, elastin fibers, water. Functional roles provides passive joint stability, guide joint movement, contribute to proprioception. So, key concept ligaments are not just passive stabilizers, they play a role in sensory motor control. So, what is the mechanism of injury? So, ligament injury occurs when force exceeds ligament tensile capacity. So, common mechanisms twisting, torsion, excessive stretch, direct trauma. So, what are the examples? Angle inversion, lateral ligament sprain, knee valgus stress, MCL injury, rotational force, ACL injury. So, classification of ligament injury. Grade 1, mild, microscopic tearing, minimal instability. Grade 2, moderate, partial tear, some instability. Grade 3, severe, complete rupture, significant instability. Key insight severity determines management strategy and rehabilitation progression. So, pathophysiology of healing. First one, inflammatory phase. So, which means bleeding, swelling, and pain. Proliferation phase, collagen synthesis, scar tissue formation. Remodeling phase, collagen realignment, improved tensile strength. Important note ligaments heal slower than muscles due to limited blood supply. Biomechanical consequences after injury, reduced joint stability, altered movement patterns, increased injury risk. Neuromuscular impact, impaired proprioception, delayed muscle activation. Key concept instability is not just structural, it is also neuromuscular. Clinical presentation acute phase, pain, swelling, limited movement. Subacute or chronic phase, instability, giving way sensation, reduced function. Severe injury, grade 3, significant laxity, inability to bear weight. Clinical assessment, subjective examination, assess mechanism of injury, immediate swelling, instability symptoms. Observation, look for swelling, bruising, joint alignment. Palpation, localized tenderness. Special tests, example anterior drawer test, ankle or knee, Latchman test for ACL, valgus, varus stress tests. So, and then functional testing includes balance, gait, load tolerance, clinical reasoning framework. Step 1 identify severity, grade 1, 2, or 3. Step 2 identify instability type, mechanical instability or functional instability. Step 3 assess functional deficits, strength, proprioception, movement control. Step 4 plan rehabilitation based on healing stage, patient goals, physiotherapy management. Phase 1 acute phase goals reduce pain and swelling, protect ligament. Interventions police principle like protection. P stands for protection, O stands for optimal loading, optimal loading, and then eyes compression elevation and gentle movements. Phase 2 subacute phase goals are restore mobility, initiate strengthening. So interventions range of motion exercises, isometric strengthening. Phase 3 rehabilitation phase goals restore stability, improve function. Interventions strength training focus on surrounding muscles, joint stabilizers. Proprioception training example balance exercises, unstable surface training. Neuromuscular control, movement retraining, coordination drills. Functional training, sport specific tasks, return to activity progression. Advanced consideration, chronic instability may lead to recurred injuries or degenerative changes. Sensory motor deficits, even after healing, proprioception may remain impaired. Key insight rehabilitation must address both mechanical stability, neuromuscular control. Indications for referral refer if suspected complete rupture, severe instability, failure to improve. Clinical case example Case 1 ankle sprain, patient with inversion injury, swelling, difficulty walking. Management acute care, progressive loading, proprioception training. Case 2, ACL injury. Patient with knee instability giving way. Management, referral, post surgical rehab. Key take home points. So, ligaments provide both stability and proprioception. Injury leads to mechanical and neuromuscular deficits. Rehabilitation must be progressive and functional. Proprioception training is essential. And the final thing is the ligament injuries remind us that stability is not just about structure, but about control. As physiotherapists, our role is to restore both mechanical integrity and neuromuscular function for optimal recovery. Thank you for joining this advanced discussion. I'll see you in next video.